Hello everyone, we're gonna keep going with our case scenario question summary. Okay, so another case you will see, okay, 70-year-old had some sort of stress, accident, car accident, motor vehicle accident, developed EF of 25%, right? And then some shortness of breath, all kind of stuff. And then they want you like, what is the diagnosis? This is stress, cardiomyopathy, okay? This is and that brings us to stress cardiomyopathy discussion. Usually substernal chest pain, shortness of breath, cause heart failure, arrhythmia, cardiogenic shock. In EKG, you see ST elevation 50% of patients, not all the time. And then deep T wave inversion, Q wave, prolonged QT in some patients, elevated troponin, mildly, not high. Echo shows apical ballooning, akinesis, basal hyperkinesis as well. Decreased left ventricular ejection fraction, coronary artery angiography with left ventricular apical ballooning but normal coronary artery, so there is no stenosis that we need to intervene with. Okay, so that's the case. Okay, another case, someone came in, 63-year-old came in with chest pain worse with inspiration. Okay, and taking aspirin, friction rub, taking aspirin. What would you do, like best next step? So this is like management of it just had an MI, by the way, and then developed that, after MI developed this friction rub. EKG is okay, no cardiac enzyme okay. This is peri-infarction pericarditis. So how would you treat it? You treat it with increase aspirin to higher dose, usually 650 to 1000 milligram 3 times daily for symptomatic patient. Okay, these are the guidelines for acute pericarditis, peri-infarction, post-infarction. Okay, and avoid NSAID, steroid, and anticoagulant. I think because it increases risk for rupture and stuff. Alright, so now you have 70-year-old man comes in with tearing, chest pain, distended JVD, okay, distant heart sound. What would you do for this patient? What is it? This is scary stuff, right? When you see distant JVD, tearing chest pain. So the best next step is bedside echo, then go to the OR. This is type A aortic dissection, causing all the pericardial effusion, cardiac tamponade. All right, now we got another patient, another guy, 55-year-old man, came in with chest pain. Of course, chest pain, it's a heart attack, it's cardiology, right? So the patient chest pain, ST elevation, right? He was given TPA. What would you do after that? Transfer to PCI facility. Okay. All right. And now let's see. What increase aneurysm expansion? This is another question. Smoking, okay. Active smoking is very dangerous. Alright, so now there's this one is interesting, it's very important to know. Someone comes in, let's say 37-year-old, chest pain, okay, neck pain, usually like has position changes with position, changes with position. That mean like maybe pericarditis, okay. And there's ST depression. There's diffuse ST elevation with ST depression. Cardiac enzymes are normal, okay. Diffuse ST elevation. And they ask, how do you manage it? What's best next step? So they're asking management of pericarditis. And the management is a prednisone. So there are different types, pericarditis and myopericarditis. So pericarditis usually have typical chest pain, friction rub, EKG shows diffuse ST elevation, new worsening pericardial effusion. Myopericarditis, the difference is they have all of that, but in addition, elevated cardiac enzymes, left ventricular depression function, ejection fraction depressed, MRI imaging showing myopericarditis, okay? And the management, you want to do NSAID is the standard to reduce inflammation in all patients without contraindication. Colchicine as well, it's good, okay? But what if the patient have CKD, let's say, that's when you give prednisone, okay? Okay. So this prednisone only in refractory cases, like somebody failed NSAID and colchicine, or contraindication, because prednisone is associated with high risk of recurrence, increased risk of recurrent pericarditis. So this is something to keep in mind. Alright, so now there is a patient came in 65, swollen lips and eyelid. Now you know what I'm going with this. This one is angioedema. So what is the best next step? Stop ACE and start ARB. Stop ramipril, start losartan. Alright. This patient has a fluttering in the chest. So AFib with mitral stenosis, what do you treat with? You give warfarin. Okay. Patient with mitral stenosis and atrial fibrillation, high risk of embolic stroke, and should receive long-term anticoagulation with warfarin. More recently developed oral anticoagulant, XA inhibitor, and direct thrombin inhibitor are not approved for this patient with valvular atrial fibrillation. Okay, so Eliquis, not for valvular AFib. Okay, it's for non-valvular AFib. Alright, this patient have chest pain, STEMI, aspirin, Plavix or Prasugrel, you know. What else do you give? For this patient, you want to give PPI, because these are increased risk for bleeding and GI bleed, you know. You want to give PPI. Now, another question, someone comes in with 6 hours, chest pain, intermittent, and then you see 1.5 ST depression, troponin 2.2, so it's ST depression, troponin elevation, he's 75-year-old, what would you do? You want to do cardiac cath in 24 hours, okay? This is very important because there are high-risk features for acute coronary syndrome, like elevated troponin. If you have a new ST segment depression, recurrent angina at least at rest or at level activity despite intensive care therapy, hemodynamic instability, sustained ventricular arrhythmia, tachycardia, fibrillation, primary percutaneous coronary intervention with the preceding 6 months, you know, within the past 6 months had a PCI, high likelihood they do another PCI. Someone had recent cabbage surgery, left ventricular ejection fraction less than 30%, TIMI score more than 2, you know, this patient needs heart cath. So to summarize what we talked about, when do you do heart cath and angina? We talked about PPI. Talked about warfarin, when do you do that for AFib? ARB is better for somebody with angioedema and cough. Prednisone increased risk for recurrent pericarditis, you want to watch out for that. Smoking causes expansion. After you give TPA, transfer to PCI, echo and OR for somebody with dissection. And increased aspirin for peri-infarction pericarditis as well is very important. Stress cardiomyopathy can happen after motor vehicle accident or so. And that's kind of a summary of this session, and then we'll continue on the next one.